Now you can simply try to look at this in video. This is the back of the patient where you can see there is so much of purpura rash. It is of varying size, so multiple small petechial or purpura lesions are there, which are around 1 to 3 millimeters. So many are like from between 3 to 5 millimeters, and so many of them are getting coalesced to form a larger lesion. So this is involving the back of the patient. You can very clearly see that it is there on the back, it is on around abdomen, it is significantly present on thighs as well. So you can see there are multiple patches of this purpura which is involving the thighs as well. Now we see this, there is large number of purpura patches are present also on the lower leg, ankle, and you can see there are so many lesions. There is ulceration of the skin as well. So there are large purpura patches with ulceration as well, and they are not at all blanchable. So when you press it with finger, there is no blanching of the lesion which is seen. So this is a very typical of a purpura lesion, which is involving back, abdomen, thighs, hands also. We can see there are small petechial type purpura lesions. Petechia are usually in between 1 to 2 millimeters. These are slightly larger, but these are totally non-blanchable purpura lesions with some petechiae. But this patient had no thrombocytopenia. So this is non-thrombocytopenia purpura rash. So this is a very typical. We should always think of Henoch Schonlein purpura, that is HSP. Now, what is this? This is basically small vessel vasculitis, and it has a HSP triad or HSP tetrad as well. So, very common, the patient will have arthritis, abdominal pain, and no thrombocytopenia, but there will be palpable purpura. And this is typical or classical triad of HSP, and it when it shows proteinuria or hematuria, we call it as tetrad. So this particular patient also had arthritis since 2 to 3 weeks. He had severe abdominal pain. That was his presenting symptom with abdominal pain. And on doing urine routine, what we found was there were 80 to 90 RBCs, and pus cells were present definitely, but it were very much lesser. So there was hematuria and there was 1 plus proteinuria. The urine protein creatinine ratio was around 1400. So this patient definitely had proteinuria, hematuria. Why we need to understand is key these patients, if these are not properly treated, may also underlie or may also undergo acute renal failure, or there can be significant worsening of creatinine, there can be significant worsening of the urea. So we always have to take care of their joints, their kidneys, their abdominal pain. We always must remember. This is almost exclusively seen in only children. This is 85% of the patients will be children only of less than 15 years, but very few patients or rarely this can also be seen in adult. In this particular patient, he was 32-year male patient, and this is much common in male patients only. This is kind of rare in adults like this one, but this patient had all these typical classical signs of arthritis, abdominal pain, non-thrombocytopenia, palpable purpura, proteinuria, hematuria. All the signs were present there with very typical purpura rash. So most of the time it is seen or it is exacerbated by some or the other infections. It can be some drugs as well. It doesn't actually matter because the treatment remains the same, and the recovery takes around 1 to 2 months. What is the treatment? The treatment is always to start steroid. Steroid is the best treatment for this. We simply start with 1 to 2 milligrams per kg body weight steroid. This patient was around 80 kgs, so this patient was put on 80 milligram of prednisolone, and the steroids were tapered off over a period of 1 month slowly. And at the same time, azathioprine was started at around 1 to 1.5 milligram per kilogram to start with as steroid sparing therapy. If azathioprine doesn't help, or if the lesions reappear or the symptoms reappear or the proteinuria, hematuria worsen, then again steroid dose may need to be again increased, and steroids may need to be tapered slowly over a period of 4 to 6 weeks. So we can taper off steroid every 6 to 7 days from 10 milligrams every week, so that it can be tapered over a period of 1.5 month. And at the same time, azathioprine can be given. If patient doesn't respond to azathioprine, or if the patient's symptoms immediately worsen after reducing the doses of steroid, such patient may need cyclophosphamide or other immunomodulator therapy. So this was all about Henoch, Schonlein, Purpura for today. Thank you.